All right, so we'll be moving to the next abbreviation. That's basically a disease condition we should be looking at, trying to talk about this disease condition and try to give the basic and knowledge that students need. We'll be talking about what is known as an idiopathic adrenal hyperplasia. Idiopathic adrenal hyperplasia. Okay, so this condition, you could say it, and this is where your adrenal glands are, right there on the kidney. They are just like the caps of the kidney. So you should know that it actually refers to a condition, and this condition is where the adrenal glands are so large. Now, because they are large, their tissues are also kind of like multiplied. So their roles are kind of like being exaggerated. So the hormones they should provide and they should produce actually are like getting so much. You understand? And most of the times it's the aldosterone that is so much. So what is it? It's a bilateral was okay, it leads to overproduction of aldosterone. Just a summary. Idiopathic means that the cause is unknown. You don't really know what is causing it. Do you understand? Um, but there are other cases caused by tumors. Those ones now and they are not idiopathic. Do you understand? We're actually trying to focus on the idiopathic. So the hormone that is mostly a culprit is aldosterone. Okay. So this is how your adrenal glands will look like. Your normal adrenal glands, can you see how it looks relatively small? But the one that is an hyperplasia, you can see how big it is. Okay. So what's the role of aldosterone? It promotes sodium retention and potassium excretion. Do you understand? It will keep sodium back into the body, but it will push potassium out of the body. Do you understand? So because it brings sodium back into the body to increase blood volume and blood pressure. Do you understand? So if aldosterone is too much, that means retention of sodium will be too much. So this kind of person will be having fluid overload. You understand the pathophysiology now. So the person will be having high blood pressures, muscle weakness, the person is weak, excessive thirst, frequent urination, lab findings to be having elevated aldosterone and suppressed renin activity and also hypokalemia. All right, so I think this is what we got. You diagnose it by trying to measure for the amount of aldosterone and also do an aldosterone to renin ratio. Okay, salt loading, fludrocortisone suppression, and captopril challenges. So you also do an imaging where you try to rule out the adrenal tumors. Then adrenal vein sampling. And for management, you give the antagonist. That's drugs that will kind of like fight aldosterone. So we call them what mineralocorticoid receptor antagonists. They'll block the receptors so that aldosterone could be so much, but it will not be binding to receptors. And these things are so coordinated that once it cannot bind to its receptor, it will not work. Okay. So drugs like spironolactone and also the eplerenone. Okay. There's sometimes surgeries, but not really. It's kind of like a medical case, not really a surgery case.